Hi, I'm Ali Bastian and I'm delighted to be joined here by Professor Adam Fox, a paediatric allergist, and today we're talking about OIT, which I've just completed peanut desensitisation with my daughter Isla, who's 2 years old, and we're just about to start Sesame, so I'm really excited to be able to ask you some more questions about it and share the information with you all. So, immunotherapy, what is it?
Great question. So, I think people think of desensitisation and immunotherapy, it's all the same stuff. So loads of different terms. We talk about OIT, that just stands for oral immunotherapy. Desensitisation, exactly the same thing. It's been around for years. It's just how it's been used is changing over time. So if you go back over 100 years, at St Mary's in Paddington, they were using desensitisation for people with really bad hay fever. And they were using injections of pollen extracts. Wasn't the safest thing at the time, and it's done quite differently now, but the principle's exactly the same. And that principle is that if you're allergic to something, you can potentially retrain the immune system to be less sensitive by giving it exposure to that thing, initially in small amounts, but then gradually increasing that amount. And it's really effective, but it has risks. And that's where the whole science of it has really advanced and gets really, really interesting.
So does it work in the same way when it comes to food allergy as it would to, say, pollen?
Yeah, I think the main difference between desensitising people to pollen, which is something, if I go back in my own career when I first started 20 years ago, it was quite a big part of our practice, desensitising to pollen. And the big thing at the time was that we were moving away from using injections to desensitise people, which could be quite risky, so you could have quite nasty reactions to those. And we were moving to what was called sublingual immunotherapy. So that was where if you had really bad hay fever or a dust mite allergy, you could get a tablet or a spray, pop it under your tongue where you held it there for a minute or so, and gradually you would become less sensitive to that allergen. But it was a really safe treatment, so it was something that people would do at home. There was minimal supervision, and the effects were real but relatively modest. So it would just mean that somebody who had bad hay fever would have less bad hay fever in subsequent years. But then where things got really interesting is when people started thinking, well, if it works for pollen, would this work for food? Now, the history is a little bit checkered here. If you go back to the 1980s, people had the bright idea of saying, well, if you do injection desensitisation for pollen, let's try that to peanut. And that didn't go well. So that study had some very, very serious reactions. So it was clear that it was never going to be as straightforward desensitising to food. And that sort of makes sense because we've always known that the reactions you can have to nuts and sesame and things like that can be really, really severe, potentially life-threatening, whereas with hay fever, it's hay fever and it's never quite that bad. Mm-hmm. So it was going to have to sort of be a journey to try and understand how this could be done safely, but using those same principles of gradually exposing somebody as a way of making them less sensitive. And so over the last 20 years, we've seen an enormous number of studies. A lot of it's been focused on peanuts. And sometimes I think people who don't have peanut allergy get a bit frustrated by that and are sort of thinking, why is this obsession with... And it's more actually that peanut allergy is sort of a model for which you sort of base the experiments that you can then apply the knowledge more generally.
Okay, so if it works for peanut, then there's a high chance it might work for
exactly
foods.
That. And what we've seen happening over the years is an enormous number of very large-scale studies confirming that peanut desensitisation can be effective and can be safe as long as it's done very carefully and in the right way. And then a much smaller number of studies to things like sesame and cashew and other tree nuts that broadly say it looks like this allergen behaves broadly in the same way as peanut. Mm-hmm. So we don't have to then go through a whole nother 10 years of studies to say, okay, we've been doing peanut desensitisation for years, now we can do desensitisation to this. In fact, people have sort of proven it, proof of principle with one allergen and then, generalised that to a range of other foods.
And is it, with Isla, our allergies are in bold. A little easier to spot on the back of a food packet, but not everybody's are. And is it something that you can do with other foods as well, or is it at the moment we're focusing on the main allergens?
Yeah, so sort of technically you could desensitise to anything, but there'd be increasingly little experience of how well that works, what the safety profile is, what you can expect in terms of the scale of the outcome, so how much you might be able to eat by the end of it. Mm-hmm. If, for example, we wanted to desensitise somebody to lupin or pea or some of the more recent but less common allergens. So what's generally happened over time is the focus has been on these sort of big ticket allergens, the ones that we know there's lots of people with. So obviously a lot of interest in milk and egg, but particularly more recently peanut and sesame and tree nuts. Mm-hmm. And in terms of clinical experience that we're all gaining, published work from being gathered from people around the world, that's generally where the focus has been. And it's been really reassuring to see over time that increasingly that we're getting a bit better at it, that we're learning more about it, we're looking at different ways of doing it, desensitizing alongside using other medications, for example, as ways of making it a little bit safer. So it's really exciting because it's an emerging field. And if I go back sort of, I think 2009, and this was front page of the newspapers. There was that first publication came from Adam Brooks showing that they'd desensitized, I think it was 7 or 8 kids to peanut, and showing that they could get children that were okay with about half a peanut and got them to the point that they could eat 15 peanuts. That was sort of, that was the watershed, and everybody was really focused on that. And when I first started in the specialty, if you went to an allergy conference, there might be the odd talk or the odd presentation about it. Now it's absolutely dominant, and when you go to these big allergy conferences, it's predominantly about food desensitization, and it's the way that things are being driven forward, which has been enormously exciting. Because as an allergist, it was always frustrating diagnosing people and then saying you're allergic, you're just going to have to avoid it. That's the option, and let's cross our fingers, see you in a couple of years and repeat the test and hope that it's gone away. But you knew with peanut allergy, the chances of that happening were small, 20% in smaller children, and by the time they're 4 or 5, if they're not outgrown it, it's not going anywhere. The chances may be a little better with other allergens. Sesame's 30%, but tree nuts is only 10%. So essentially we were very passive as doctors, and that's never great for patients or doctors. It's basically we were a diagnostic specialty. But then over the last 10 or 20 years, we've seen that really change. And now we're able to make the diagnoses, but say to patients, actually, there is something we might be able to do about this.
That must feel great, just to feel more on the front foot with it.
Yeah, I mean, it's just being able to feel that you can help you, and that's what we're there for. And whilst, of course, it's incredibly important that people have accurate diagnoses, know what they need to carefully avoid, to at least have the options open there. And I think this is a really important point. It's not the treatment for food allergy. So food desensitization has definitely changed things, but I'm always, the first thing I'll always say to patients when I'm talking about them is there is another option. There is a different way of treating this food allergy. It's not the way of treating it.
Right.
For plenty of patients, probably the majority of patients, the right thing to do is to continue to carefully avoid it. And yeah, it's great if there's a chance it might be outgrown, but even if it's not, certainly for some allergies where it's not a particularly common thing, it's relatively easy to avoid, food labelling thankfully has got better, that actually the right thing to do is not to go through a process that does carry risk in order to put yourself in a better position. The right thing to do is just avoid it.
Right.
So it's really important whenever we're talking about food desensitization to remember that this is a pretty complex process of what we now refer to as shared decision making. I don't know what the right thing for you and your daughter is. You probably know more what the right thing is, but I know more about food desensitization, I hope, than you do. And so it's us coming together with you and your own personal experiences, what you want from treatments and what your expectations are, and what how you envisage your child reaching their full potential, together with my experience and the knowledge I have of it. That together enables us to come together and make what we believe to be the right decision for one patient. Now, of course, what's right for one patient isn't right necessarily for the next family or the next patient. And in a way, that's what makes my job so interesting, because I'm always fascinated by the enormous breadth of ways that different families will respond to actually broadly the same problem.
Yeah,
it's so different. And how you've responded to it with Isla will be influenced by your own life experience, your own medical experiences, what you know about her as a person, and those sorts of things. And we have to sort of bring that together with, well, what would be the best option as a family for you guys?
I think that's really crucial, actually, because when you first get diagnosed with, when your child is first diagnosed with allergies, that's our experience, it can feel quite out of control.
Yeah.
And, for me, the way my mind works, I wanted to fix it. I want to understand more about it. I kind of did a deep dive into it, trying to find out what was available. But just to sit with a clinician and to have more of a sense of agency in what the next steps are, and deciding, collectively, like what's right for families, got to be so important. And I think for us it's just being part of the process that's been quite empowering. You mentioned before about the risks of OIT.
And it's really, really, really important to discuss this. And in fact, probably the first risk happens before any sort of conversation about any treatment. It's the misconceptions about it. So it's this belief, and it's funny because sometimes patients will come in and they have some of my patients have seriously done their research and they've got an enormous knowledge about it. Some patients have done a bit of research, but sometimes they don't have much context their research. They're not doctors, so why would they? And so sometimes they understand it in quite a different way to my understanding of it. And that's why it's always really important to have very, very frank and open conversations at the beginning, so that you both know what it is we're talking about. And I think the first misconception is this idea that it's some sort of cure, because it absolutely definitively isn't. But for most patients, essentially what we're aiming to do, if it works, is to just make that patient less sensitive to the thing that they're allergic to. And if you're able to achieve that, and there are risks in getting to that point, even when we've got to the point that they are able to eat more of that food without having a reaction, they're sort of committed to continue to eat that food regularly at a certain level in order to maintain the effect. And if they stop doing that over a relatively short period of time, they're just back to where they started. And that was one of some of the really important original studies around peanut allergy, had to establish how long did this effect last for, and did you need to keep eating peanut? And the answer was pretty unequivocally yes, because if you stop, then you're just at risk of a reaction again. And in fact, when people first started talking about desensitizing, we were a little bit nervous about the fact that actually, was this a good idea to go down this route? Because if we know what teenagers are like, we know they're not great at taking their medicine. If you've got a 15-year-old who has been successfully desensitized, but needs to eat 2 or 3 peanuts 3 or 4 times a week in order to maintain the effect, and as a consequence feels that he can be a little bit less careful about his peanut allergy, but he isn't really complying brilliantly with his treatment, so he's only having it once a week or maybe even less than that, is it actually more risky that kid is going around thinking, I'm going to be all right with peanuts, but actually isn't doing the treatment properly and maintaining the effect, and he's actually putting himself at increased risk? Right. And then, the whole thing was not a good idea. But actually, I don't think that's really turned out to be the way that it works. I think because we spend a lot of time speaking to patients beforehand and parents and making sure they're fully engaged, there's a pretty clear understanding that this is, you're inducing a temporary effect that you do need to maintain, and everybody realises that's important. And actually, maintaining the effect doesn't have to be onerous. It can be as simple as having 2 or 3 peanut M&Ms 3 times a week, which is very doable for most kids if they're engaged and they understand why they're doing it and they're keen to do it. So just going back to sort of those key risks, the risk is that you're essentially putting your child in harm's way. You are giving them the thing that we know that they're allergic to. Now, we start at very, very small doses, and that gradually increases. And when we increase the dose, it's very important that's done under medical supervision, because that's the bit where they're most likely to have reactions. But in between those increases in doses, as you know, you have to keep giving the dose at home. So every day we're asking, it's a pretty big ask, is we're asking you to give your child peanut if they're allergic to peanuts. Now, yes, it's in small enough quantities that they've already demonstrated they're okay with, but whilst the dose might be the same every day, the child isn't the same every day, because there's days when they've got a runny nose, or they're under the weather, or they've had a late night, or any number of other things that will mean that actually they're more sensitive to the allergen than they were, which means there is a risk they can have a reaction. And if they have a reaction, sometimes those reactions could be significant. And certainly in older children, particularly when they're being desensitized, an important minority can have really nasty reactions. And so that adds, firstly, a degree of anxiety. It means, yes, there's a whole range of rules and things that we try and put in place to try and mitigate that risk, but that risk is there. And you've got to be able to deal with that. Now, you're the one that's taken this home and been through it. I've never had to do that.
Right.
I just have to wait for the emails or the calls in case there's a problem.
Yeah.
But how did that feel?
Right at the beginning, it was pretty nerve-wracking. Because you have this food that you absolutely religiously avoid, which we had done with Isla, and suddenly it's in the house and we're dealing with it, and I'm preparing it and I'm giving it to my child. And like you were saying, it's that constant assessment of how she is that day, and is it the right time? And the golden rules that we get given are really, really helpful. I think that's very supportive. There's a big, a sort of information pack, and you have a flow chart to follow. Yeah. And so you can start again to have a bit of agency and get a bit more in touch with your instincts. I'd say that's a positive thing about it, is that think, do you know what, something, soft today, I think we'll, cut the dose or hold it back, or, we're instructed with how to deal with that. But in the earliest stages, actually, while we were still learning the ropes, you guys are very contactable, and that is really, really helpful.
Yeah, I think that's really, we've always known that that's important. If you're going to offer this sort of service, you can't then leave people out there on their own trying to deal with it themselves.
Yeah.
For two reasons. So firstly, it would make life much harder for people to make those decisions themselves if they feel that they're not properly supported. But also, I think, we learn this by looking at practice that goes on in different places, that when parents are left to do that, sometimes they can go down some slightly funny avenues. Over time you meet patients who have sort of decided that they're aware this is going on in other countries. They didn't feel that there was adequate support to get this in the UK. We have lagged behind a little bit. And so they've just decided to do it themselves.
That was one of my questions.
Yeah.
And this isn't, having done it myself, this isn't something you do solo. I mean, absolutely not. And especially when you go for those updosing for appointments, it's so important to be in a clinical setting. And so because, you're pushing up that dose every few weeks, and you have to make sure that it's tolerated in a safe environment before you take that home.
Yeah, I mean, I think that is really, really important. Thankfully, what we find is that if it's done properly, severe reactions are rare, which is great. I think that's predominantly because we've learned all of the signals that we need to look for that would increase the likelihood of having a bad reaction. So, in fact, just very recently, we had a child who came in for an updose, and the parents said, yeah, they're absolutely well, they did look well. But when we did their temperature, they actually had quite a significant temperature, and it turned out that night they did have a stonking cold that came on, and so we actually didn't progress because of that on that day and didn't give that increased dose. And there's a reasonable likelihood that could have caused the reaction just because the child's immune system is a little bit more sensitive. So I think when we apply all of those different things, and I think it does feel manageable. That's certainly what patients tell me. You might feel otherwise.
No, I don't. I really do. And from where we started to where we are now, I can't believe really the journey that we've been on. Honestly, it's been very confidence building for us as a family, and touch wood, it did go smoothly for us. And I think because everybody's so aware of, like you were saying, the different factors that could potentially cause a reaction or trigger a more severe reaction, but no, it was actually a smooth process for us. I felt like I was giving her cyanide the first time I gave it. It was literally like the teeth, my hand was shaking and everything, and then you do it, and then under all the supervision that we were under, and it goes okay, and then that's where the journey to growing in confidence and thinking, actually, this might be working, this might change things for us. It's an incredible journey, but it's nerve-wracking, I'd say, at the beginning. Yeah,
and I think the thing is, of course, your experience has been very much coloured by the fact that it worked and it was a smooth journey, and it's not always. And I think that's really important, because firstly, that anxiety that's provoked by giving the dose, for some parents, actually it's a little bit overwhelming. And sometimes with those families, it's clear it's just not the right thing to be doing. I mean, the thing to remember is that the purpose of this treatment is to make the child safer by being less sensitive, really as a means to improve the quality of life of the family. And if actually the way that you get there creates so much anxiety that really has a negative impact on quality of life, it's not the right thing to do.
Absolutely.
But being honest about that right at the beginning is firstly really important, but also really difficult. So I have had a couple of families where the treatment's been going absolutely fine, but it is clearly creating so much angst at home, and there's so much anxiety when that dose has been given that it's just not the right thing for that family.
I do remember us hitting a moment like that, and I emailed you actually because it was also trying to give a 2-year-old the same thing every day. It's been like mental gymnastics, trying to find different ways to make this happen, and we had literally tried everything, and I did hit a wall early on, and it was nothing to do with actually how the treatment was going and how things were unfolding, but just simply the psychology of it at home.
Yeah, absolutely.
And it was like, and then we did it, my husband and I kind of went to ground, and we were like, we need to find another way. We changed location, changed what we were mixing it with, all this kind of stuff, and managed to inspire her again for a little bit longer. But it's constant. Anyone with a toddler knows what it's like.
Absolutely. And from our side, and we've had these challenges come up, and in fact, as often as you're getting contact about reactions and concerns about dosing related to that, we're getting contacted by parents who are finding that challenge of just getting their child to eat the food.
Yeah, and containing your own emotions within that, because sometimes you feel like, just eat it, just eat the thing, this will help you, please. But it's like you can't, trying to hold that balance of holding down what you're experiencing as a parent.
And we get to see that dynamic in the clinic as well when we do the increased doses, and you can see how, almost sort of with our first dose, you'll sort of hold your breath as to what's going to happen, and you get these kids who just open their mouth and the parents stick it in and it's done. You think, wow, this is going to be straightforward. Yeah. Or you get the kids where literally they're chasing their children around the room, and the kids can already smell, this is a great way of manipulating my parents because I can get them to do anything.
I've named it affectionately the Feeding Children Olympics. Right. Is basically what happens in these clinics where you just see everyone going around negotiating, trying everything they can. Yeah, if you can try and stay in a kind of light mood over it, then you kind of stand the best chance.
Yeah, we've realised that we need to involve for a number of patients a dietitian who's developed real expertise. I'm very lucky. I work with a dietitian who's been very involved in the clinical trials around these studies, so she's really got a lot of experience at different ways of giving the food, and sometimes, especially in the younger kids, hiding it and disguising taste, which is really difficult with peanut, for example, because it's got a very, very distinctive taste. And very, very occasionally involving allergy psychologists, but then that's usually for a broader picture of anxiety. And sometimes actually the OIT isn't the issue, it's just uncovered the fact that the level of anxiety has become, a little bit disproportionate, and that's really important. Yeah. And again, it goes back to what are the risks of this? I mean, another risk is not just the risk of these reactions that is very real and needs to be managed and is an important part of understanding what's going to be involved, but also the risk of what it's going to do to the family dynamic. Sometimes it's not helpful if there's an inordinate and disproportionate focus on this child has got to eat this food at this time, and it's it's not the right thing for that family. Yeah. So I think I've had one child who's dropped out of a treatment program because they just refuse to eat the food, and I remember seeing that in clinic in practice, and it wasn't pretty, and it was it's like, okay, this is not the right thing for this family. Yeah. And they could see that, and sometimes they're it's frustrating. The parents are very committed, they've decided they want the outcome, but their child, who of course is 3 and has no understanding of the implications of their allergy, just isn't playing ball. But for most people, it's absolutely fine to manage an allergy by just carefully avoiding it, but just really understanding what the risks of that are, and making sure that there isn't disproportionate anxiety about fatal anaphylaxis, which is incredibly rare. Because actually for a lot of patients, when we have those first conversations about OIT, they've come sometimes from quite a long way because they're convinced their child is going to die of that food allergy. And having a really frank conversation about the risks and how we can mitigate those risks, and how the risks of anaphylaxis compared to the risks of other things that happen in children's lives, and unfortunately other bad things that might happen, is really, really helpful. And by the end of it, they're feeling much less like that they don't necessarily need to do the OIT, that actually they're more comfortable being able to just live their life with a better understanding of what that risk is. And I think sometimes as doctors, we're not great at doing the job of really informing patients of getting that risk in context. And some people come absolutely sure that it's 50-50 whether their child with a food allergy is going to have a fatal reaction, when actually, although yes, it's a possibility, it's a very remote one, and yes, there's ways of managing that risk sensibly, it shouldn't be taking over people's lives. And I'm always very clear that we are never doing OIT in order to save the child's life, because that's that's the same mentality as saying there is a risk of you getting run over by a car, so you're not going out the house. It's it's not for that.
I remember someone saying to me, it was my father-in-law actually, I think he said, because in the early stages, I think for a lot of us as well, before we get to this point that we're discussing OIT, our children may have had reasonably severe reactions that have led us to this moment, and so it's like, okay, parking, that's happened, but we've been frightened probably at one point, and so it's easy for that to sort of resurface. And I think he said to me, she's going to be like Rapunzel. You can't keep her in this. Can't keep her in this flat. You can't. You got to start to get out into the world. And so we saw a psychologist, actually, family psychologists, have found that really, really helpful as part of our journey. I think it's great if you're helping people find that kind of support.
I think an enormous regret of mine is that within our NHS service, we've not been able to offer as much psychological support as we would like to. I mean, personally, I feel that, and in fact, in some big US centres, everybody diagnosed with multiple food allergy gets a session with a psychologist. we were really lucky at St Thomas's. We got charitable funding to set up a paediatric allergy psychology program. We've now had we've had a number of brilliant psychologists who now work with us, and that's been fantastic. But even they can only see a tiny proportion, and of course, inevitably, it ends up being rationed for the most severe end of it. The people who has really got severe anxiety around food, whereas I think everybody would benefit from that
massively.
But and it's not really even about money, because if you had all the money in the world, we haven't got the psychologists. And having psychologists who really understand food allergies are really important here, because I think one of the frustrations when you've got concerns about allergies as a risk, or go to see a psychologist who they themselves don't know what proportionate risk or what proportionate anxiety is, because they're not sure how dangerous the food allergy is, because not unreasonably they don't know much about food allergies. Whereas knowing somebody really understands food allergy but is also a psychologist is an enormous benefit. And there's enormous value in that.
Thinking about OIT, is there a particular time in a child's life that would be the optimum intervention moment, or how do you look at the individual?
That's a really important question, because actually there's been a bit of sort of historical context of how this has all evolved. So originally the first important studies on peanut desensitisation, where this all sort of started about 25 years ago, were very much focused on older children, simply because we knew that younger children sometimes outgrew their peanut allergy. So 20% of kids would outgrow it, but usually by the time they're about 5 or 6. So it sort of made sense that if you're going to try a treatment to see whether you could make them less sensitive, that you should focus on kids who weren't going to outgrow their peanut allergy in the middle of the treatment, because it was going to make the results much harder to interpret. So those original studies were done on kids from 7 and upwards. And that showed that you could, get kids who would react to, a quarter of a peanut or something like that, or sometimes even less, and get them to the point that over the course of a number of gradually increasing exposures, be able to eat 4 or 5 peanuts, sometimes more. So that's great, and that's now been translated into what then became a very, very large research program funded by a company called A-Immune. So A-Immune are actually a spin-off from one of the US food allergy charities that thought, there's a real angle here. This food OIT is going somewhere. Let's turn this into a big research program. But that means a whole big commercial component to it. That then resulted in studies that led to the licensing of Palforzia. So Palforzia was these peanut capsules that just contain really, really, really accurately and carefully measured amounts of peanuts, so that when you're doing the program, you know exactly how much peanut you're giving, even when it's tiny doses. Because yes, you can do all of these things. You can do desensitisation with the actual food, but then if you're having to start at a 1 milligram dose, you can't realistically, even in a hospital, never mind at home, reliably measure 1 milligram of peanut protein. Remember that only a quarter of a peanut is actually protein. So you're talking about measuring tiny, tiny amounts, and it has to be really, really accurate. So whilst this sort of treatment is really helpful, unfortunately, it does mean that it adds an expense into it. And as soon as you involve pharmaceutical companies, you know it's going to get expensive. And that's certainly, I think, been a very valid criticism of the way things have developed, that suddenly what you could potentially do with a jar of peanut butter has become something that requires thousands of pounds worth of medicine, even though, of course, the medicine itself is just peanut powder. Mm-hmm. But it is what it is. Palforzia got licensed in the US December 20, got licensed in the UK in October 2021. And what's been really great is that in February of 2022, it then went through NICE approval, which means it's approved for the NHS. Being approved for the NHS and being able to be delivered on the NHS are two quite different things. It requires a lot of reorganisations of clinic and staff and space and all the rest of it. So predictably, it's been a slow start in terms of getting that out there to patients. Mm-hmm. But what it looks like in practice is you can get a child who comes in, and then they'll have this series of about 11 visits, during which they'll be given increasing doses of these peanut capsules that you just open into a little bit of mush. There's a little bit of flour inside, and then the child eats that, and then they do that at home on all the days in between. That showed good results. So consistently over these large studies and in clinical practice, you're able to get kids between the age of 4 and 17 who it's licensed for. You can get them to go from eating, being sensitive to a very small amount, to being okay with at least a peanut's worth of peanuts. And after a year of doing that, if you bring them in and see, right, how much peanut can you eat now? Lots of them will be okay with 3 or 4 peanuts. Mm-hmm. And, everyone feels a lot safer if you're able to eat that much. the question, it now feels like a distant memory or question, was, what age should you be doing this? Because what came from doing those big studies was the very clear observation that you get very quickly once you start doing this at any sort of scale, that desensitising the 4-year-olds is a very different story to desensitising the 16 and 17-year-olds. Now, I don't want to be unfair to teenagers. Yes, they bring a lot of logistical baggage to coming to their visits and all of those things. But it was pretty clear that the ride was a lot bumpier for the older kids. Right. They much more commonly had side effects. It was much harder to get the doses up. They commonly got tummy aches and things during the early stages, whereas you saw less of that in the younger kids. And that got a lot of people thinking, why are we waiting till they're, this point that we think they've missed outgrowing it? Why not just start it earlier? Because if there's going to be less side effects and it's going to be easier and you're going to get better outcomes, maybe we should just be getting on with it sooner. And there's now been a series of really important studies that have shown exactly that if you desensitise younger children, and sometimes it goes all the way down to sort of 9 months of age, so almost straight from diagnosis, these kids potentially come in 9 months of age, they've eaten and sitting with a bit of peanut, they've had a reaction, they've got their confirmed allergy test, that they actually move straight on to then a process of making them less sensitive. We know from sort of other areas of allergy that generally your immune system is a little bit more open-minded about changing the earlier you get in with these things, and that actually maybe the results will be a lot better. And what the studies have shown is quite significant differences, that you seem to see less side effects, so it's a less bumpy ride and it's a more straightforward process. But also at the end of desensitising, when you've got them to the point that they're eating a peanut's worth of peanut regularly, when you then bring them back a year later to see how much they can eat, it's way more than you find when you do this with older kids. So essentially the immune system has changed by a much bigger degree, and we commonly get kids coming back and eating 20 or 25 peanuts worth of peanut. Now, that really adds a degree of value to the treatment, because nobody is worrying that their child is going to accidentally eat 25 peanuts. And whilst you still have to maintain the effect, you can do that with a very modest amount, 1 peanut's worth of peanut, what Isla's been having over the longer term, and know that there's a much bigger buffer. So the vogue is very much now towards just getting in there earlier for all of those reasons. Safer, more effective. And I think this has been really exciting, because we've suspected for a little while that maybe it even goes beyond that. Maybe for some children, if you desensitise them in that window where sometimes they just spontaneously outgrow it anyway, maybe desensitising is giving them a bit of a shove towards that outcome, i.e., for want of a better word, a cure, or what's referred to as remission, So a big study that was published in 2022 that was coordinated from Stanford in the US, and they got a couple of hundred kids with peanut allergy, but between the ages of 1 and 4, so they went for that early window. They successfully desensitised the majority of them. As expected, it was with protocols that have already been known to work. But then they did something really interesting, because at the end of the period where they brought them in and got them to eat large amounts of peanut, they said, right, you guys aren't going to continue eating peanut every day. We're actually going to tell you to stop eating peanut, and then we're going to wait 6 months and bring you back in and give you this large amount of peanut again to see whether you're still okay with it or not. Because if you are still okay with it, then you're not really just desensitised. We can technically say you're in remission. And they did exactly that. 30% of those kids, when they came back, compared to a much smaller percentage in the control group, 30% didn't react. The other 70% did, but they were still successfully desensitised. So they still had a good outcome. Yeah. They were still way less sensitive to peanuts, but they clearly were going to need to keep eating peanut to maintain the effect. But you had 30% who were in a really nice position, that actually they've gone from being allergic to actually now not eating peanut regularly, but not reacting even to very large amounts.
Wow.
So the obvious next question is, well, what was different between the 30% that went into remission and the 70% that became allergic again or continued to be sensitive? And there were 2 big factors. Most important one, age.
Right.
The younger they were, the more likely they were to get that really good result. And the other thing was the size of the allergy test. So I think we're now in a position where when you diagnose a small child, a baby with a peanut allergy, and their allergy tests are not particularly high, you're sort of thinking, okay, we could potentially really do something for you here. But it's one study. It needs, needs validating and repeating, etc. Yeah. But I think there's pretty broad consensus now that there's enough published data to say that this is a sensible approach not for everybody,
Yeah.
but to at least be talking about with your patients, saying, look, this is the data, this is the, these are the options, these are the possible outcomes.
Wow.
And that's a real revolution in our practice.
Yeah.
And of course, over time, this is sort of, being broadened out to not just peanut, but thinking about tree nuts and about sesame, and about other allergies as well. So it's been really exciting times, and it's fantastic to see this sort of research coming out from very, very reliable sources that is saying that this is a real advance in the specialty. This is actually getting to the point that if you get in there early with the right kids, you can actually completely change their outcomes, and that's beyond exciting.
It's huge, isn't
Yeah.
it? Absolutely huge. For the older children, just to ask, is it still something that a conversation that they could potentially be having with their allergist about?
Yeah, absolutely. So look, Palforzia for peanut allergy is now available on the NHS. So whilst it's the numbers are restricted, very much hope that provision is going to grow. But again, it's not for everybody. And interestingly, I think when people first developed this, and I remember when this was first being talked about way before it got its license, everybody imagined that everybody with peanut allergy was going to want to do this. But that's because everybody had quite a superficial understanding of it as, either a cure or something that was, going to be really straightforward to do. And of course, it's not. It's a really significant undertaking that carries very, very real risks. And actually, by the time you've had those conversations, especially with people who have been managing their peanut allergy for many years and often feel, okay, it's not great that I'm allergic to this, but I have found a way to deal with it. And I've got other priorities in my life that, I've got GCSEs coming up. I can't really take this huge amount of time, or I don't want to take the risk that's going to be involved, or I don't want to do the daily dosing or the restriction around dosing because they have to avoid exercise for an hour before and 2 hours after, which for older kids is a much bigger deal than smaller children who don't really have the same restrictions. The majority of people actually, after a proper conversation, will actually say, no, it's not for me.
Right.
And I think as an allergist, I know that if everybody's saying yes, I'm not telling them the full story, and it would all fall apart halfway through the treatment, and that would be a disaster. So
it's a different kind of discussion.
It is. Well, I think at all levels, it's really got to be completely upfront, because if they don't have their eyes wide open about those risks, then the bad things are going to happen. They're going to disengage. It's not going to be done properly, or they're going to not want to carry on the treatments. And I really don't want to treat people that aren't fully informed, and I want them to sort of be fully engaged and complete the treatment. And in a way, the fact that lots of people will not want to do it, in my mind, is telling me that I'm telling them the right things, because most people are the vast majority are completing those courses of treatment, which is great. So I think those key messages are: there are risks. It's not a cure. It's not for everybody. Yeah. But actually, the starting point of a lot of consultations I have is people are saying, I've come to see you because I want OIT for my child, and their understanding isn't quite. It isn't completely realistic, and so often there's a bit of a reality check first. And whenever I have those conversations about OIT, sometimes people are trying to bite your hand off, say, when can we start? When can we start? And it's always, we're not starting straight away. We're not starting till you've had a good think, you've read very detailed patient information leaflets, you can look me in the eye and say you absolutely understand those risks, because until that point we shouldn't be starting.
Yeah, I guess, putting myself in the position of a parent, and as an allergy parent, you think sometimes it's got to think, where is it coming from? Because it could, I have the propensity to really want to drive this situation, but it's about the child. And so, it's her allergies. It's her, even at this little age of 2, it's her body and her, and I want to instill that sense of ownership, actually, of it all from early on, so she learns how to cope and how to be in the world and manage it. And so where else is this available?
So this is going on around the world, in different ways in different places. I think one of the things parents often find very frustrating is that there's no consistency in terms of both provision or the way that it's done. So you'll find that, for example, there's a lot of provision in the US. This has sort of got a lot of traction there, but it's done in different ways. People have got different protocols. They've got their own ways of doing things. And so if you look at how it's being done in California and how it's being done in Atlanta, and those are big centres that a lot of people are going over to, that it'll be quite different, and different in the sense of how many visits it takes, guess what the top dose that they get to is, and the whole way that it's done and the way that it's billed. There's a lot of differences. It's going on in continental Europe. I have a number of patients who have been travelling to France, and within the NHS there's pockets of practice. So thankfully now we've got Palforzia license. That's starting to emerge. There's been other centres where they've been doing a lot of really, really good research studies, and those are still happening reasonably regularly. So there's opportunities there. Some of the services, our own service at St Thomas's has got a milk desensitisation service. So there are options in different places, and sometimes it requires what I discover is often when I'm seeing patients, they're finding out through social media, which is the Wild West, as you know, and they're getting on Facebook groups and things. So one way or the other, I think patients are finding us.
So my last question for you, Adam, what's next?
Well, I think we've got this. There's a strong sense that we're at the beginning of this journey. I've been desensitising smaller kids, to peanut for maybe 2-3 years. The Palforzia program's been going since October 21, so we're only a year and a bit into that. We're still learning loads of lessons. It's great collaborating with colleagues and chewing over these difficult cases when they happen, and working out with patients the best way of managing these things, and we're getting better at it, and we're able to speak to colleagues now in the US who've got a little bit more experience because it started earlier, and learn lots from them, and colleagues elsewhere in the world. So this is definitely the way forward. I cannot see a scenario that in 5 to 10 years it's not reasonably standard practice to be desensitising small children in the way that we probably are now. But there are loads of other things coming down the pipeline. I mean, it's been great to see just how much research has been happening around this. So people are looking at different ways of desensitising. So they're looking at doing oral desensitisation but alongside other medications. So things like what are called biologics, which are monoclonal antibody medicines. Sorry, I'm talking medical here.
No, it's good. It's interesting. I'm with you.
So these are this sort of a relatively new type of medicine where actually people have sort of thought, what's the problem going on with the immune system, and let's design an antibody that gets in the way of that process. Wow. So it's revolutionised treatments of things like rheumatoid arthritis and inflammatory bowel disease and lots of other conditions. And we've got these monoclonal antibodies that get in the way of allergic reactions. And what they've been doing in the US is looking at the kids who don't get on very well and have a lot of side effects with desensitisation, and saying, let's get them on this medicine for a few months that dampens all these allergic reactions down and desensitise them while they're on it, and then they can sort of wind back on that medicine. It's not a great approach from a UK perspective because these are really expensive medicines and they need regular injections, and it's sort of more suited, I think, to a healthcare economy that incentivises use of very expensive drugs, which we're not. So I think probably what's more interesting is different ways of doing the desensitisation. So I mentioned right at the beginning of when we were chatting about the way we desensitise to pollens, and we do that with tablets or squirts that just go under your tongue, sublingual immunotherapy, very effective for those allergies. Well, actually now there's some really exciting studies looking at sublingual immunotherapy for peanuts and nuts. So an entirely different way of doing it. And the benefit of that is there's way less side effects. So you're using much smaller doses, but you're giving it in a more targeted way. So rather than just swallowing it, it's staying under your tongue for a couple of minutes, and that seems to have more of an immunological effect. Now, there's also a peanut patch. So this is what we call epicutaneous desensitisation. So where the peanut is put onto sort of a sticky plaster, the child then sort of puts on somewhere on their body, and they replace it every day, and it goes on for a long time. Now, that I think a lot of us are really surprised that seems to work. It's still going through clinical studies, but whilst the size of the effect for both the sublingual and the epicutaneous aren't quite as much as the oral immunotherapy, they have way less side effects and the risk of anaphylaxis is a lot lower. So that's really attractive. And I suspect that what we'll end up doing is a hybrid. We'll probably start people off on these sort of safer ways of doing it with less side effects until we can actually get them up to a reasonable level of tolerance, and then maybe move into giving them oral exposure as a way either of cementing that or even progressing that. Right. So there's going to be a lot of mix and match, and there's a load of research to come, but it's a really exciting time. And there's other forms, so something called oral mucosal immunotherapy, so a little bit like the sublingual, but actually a toothpaste that's got peanut in and that they literally just brush their teeth with every day as a way of exposing the immune system.
I mean, it takes away the chasing your toddler around the kitchen.
It certainly does. Well, I think some kids, they want to have their teeth clean. So exactly. So that might be a challenge as well. Yeah. But I think this, where we need to improve immunotherapy is we want it to be safer, we want it to have less risk of reactions, and we want the outcomes to be better. We want them to be longer lasting, less reliant on the regular exposure. We want the effect size to be bigger, so we want kids to be able to eat loads of the food rather than just a little bit of the food. So there's so much further to go, but there is a sense that actually this is now out there and in clinical practice as opposed to just being notional, which it certainly was for a long time.
Yeah, it's huge, isn't it? And I love talking to you about all of this, Adam, because it's there's a sense of hope around it, and that things are moving forward. And every allergy journey is different, and every decision that's made for an allergy family is going to be what's right for them. But I always feel a sense of possibility when I speak to you, and that is really lifting.
Yeah, I mean, I think I feel really hopeful about it, and I sometimes say to patients, and I don't want to commit to anything, but I always say to sometimes parents who are looking at their lovely baby and who's just got this long list of food allergies, and they're understandably just despairing of it, and I sort of say, look, I think the likelihood of your baby growing into an adult who is avoiding all of these foods is really unlikely, because there's so many angles here. There's so many different treatment options. There's so much research focus going into this that only one of them has to really work, and already we're seeing signs of that. That I think the future does look hopeful, but that unfortunately doesn't take away from the fact that it's really challenging. You've lived this.
Yeah, day to day.
Yeah.
Sometimes when people say with the best will in the world, they're like, oh, maybe she'll grow out of it. And I feel like, yes,
thanks.
Maybe that will happen, but that is not what I'm dealing with today. Yeah. And so what you're kind of looking for in that moment is empathy and support with what you're dealing with.
And I think there's another really important point there, which is that it's sometimes a little too easy, and I think this is something we're in danger of as physicians, of getting carried away with the exciting stuff where we think we can do these wonderful things that we usually have a sort of disproportionate sense of what we can do, and forget the really important basic stuff, because managing food allergy is not about OIT. That is one aspect of it. The crucial stuff is still getting the diagnosis right, making sure that there's proper education around how you can protect your child, identify, treat reactions effectively. That will always be, the bread and butter basic stuff is always going to be the most important thing. And that wraparound that sometimes comes from specialist dietitians or the psychologists, or sometimes just having a community that you're part of that means that you're getting properly supported with all of that, is always going to be more important than sort of the fancy stuff. And that should always come second. And it's really important to not get too focused. I think I'm saying this now to myself, to not forget the important stuff that has a bigger impact on quality of life. And I think actually for me, what I've learned is that sometimes one of the biggest impacts of food OIT is the interaction that happens on the regular visits that you get with the specialist nurses and the doctors, and the education that ends up, and the conversations that come from that mean that you feel so much more empowered in that extra degree of agency. And almost the fact that your child can now eat a few more peanuts than they previously could might actually not turn out to be that important, because you don't know what accidental exposures they're going to have. But spending time with people who sort of get it and understand it is always of value.
Absolutely.
And I think for me that's always been one of the challenges with these quality of life studies that are done about how much of an impact does food OIT have, because how do you separate out, you certainly see this in research studies, the benefit to people's sort of sense of empowerment from just spending time with people that talk about allergies a lot, and meeting the other patients that are on the unit at the same time who have got shared experiences and their own sort of tips and tricks of how they've managed things, and how much is from the actual treatment itself. And I don't think we really know that.
No, but it's very real what you're saying, I think, and you can feel quite alone with it all when you first are diagnosed, and and also even getting to that point of diagnosis can be quite difficult time, but then connecting with the allergy community and sharing experiences and all of that, it's just golden. It's so
I think there's enormous value to that, and sometimes we try with varying degrees of success to organise the clinics that we run with running similar allergens on the same day, so that families get to meet each other. And
at St Thomas's, they'd sit the babies. When I was in with Isla and she was tiny, they'd always put me with another mother with a baby, and even that, especially that was through lockdown and COVID, and it was a really valuable time actually, just to connect with another parent in the same situation.
Absolutely.
Oh, thank you so much. It's been
Pleasure.
lovely to chat to you. Really appreciate it. Thank you.